students. I welcome you all for another session of RISA DNP online academic activities today. Today we have some interesting exam theory as well as practical oriented topics. To begin with, I request Dr. Ammu to present the first question. Over to Dr. Ammu and Professor sir.
Good evening, sir.
Good
Today's
evening.
my topic is anatomy of IJV, indications and complications of IJV cannulation. Coming to the anatomy, internal jugular vein is a paired venous structure that collects blood from the brain, superficial regions of the face and neck, and delivers it to the right atrium. It's a runoff of the sigmoid sinus from posterior cranial fossa and exit through the jugular foramen, lies in the carotid sheath, accompanied by the vagus nerve and carotid artery. Drains to the brachiocephalic vein into the right atrium. Landmark under the medial border of lateral head of sternocleidomastoid, carotid is medial to the internal jugular vein. Sedilot's triangle is formed by the medial sternal head of the sternocleidomastoid medially, clavicular head of the sternocleidomastoid laterally, and superior border of the middle third of clavicle inferiorly. Recommendation to cannulate IJV is to go at the midpoint between the clavicular head and the mastoid, or 1/3 of the way closer to the clavicle. Coming to the different approaches, first is the central approach. The central approach is at the apex of the Sedilot's triangle. Coming to the anterior approach, at the level of the cricoid anterior to the sternocleidomastoid muscle. Coming to the posterior approach is posterior to the sternocleidomastoid muscle. In anterior and central, the approaches entry angle is between 30 to 45 degree, pointing towards the ipsilateral nipple. In posterior approach, it is towards the sternal notch. Supraclavicular approach is the last approach in interscalene groove 2 cm above the clavicle. Direct the needle caudally and medially. Then coming to the indications of IJV cannulation, CVP monitoring, assessment of volume status, like for major surgeries involving large fluid shift, blood loss in a patient with good heart function, major traumas. IV volume assessment when urine output is not reliable. Example, chronic renal failure, radical cystectomy, etc. Frequent venous sampling, drug or fluid infusion in case of inadequate peripheral IV access, chronic drug administration, administration of vasoactive and veno-irritant substances, rapid infusion of IV fluid, and total parenteral nutrition. Coming to the temporary and permanent hemodialysis, placement of temporary pacemaker wire, surgeries with high risk of air embolism like sitting posture during posterior cranial fossa surgeries. Coming to the complications of IJV cannulation, complication during central venous cannulation and can be divided into complication due to catheter presence. During cannulation, during access and insertion, arterial puncture with hematoma and infection, airway obstruction can occur, arteriovenous fistula can occur, air embolism if negative pressure within the venous system is there, nerve injury like phrenic nerve, brachial plexus, stellate ganglion can occur, hemothorax if the subclavian artery is lacerated, phylothorax if thoracic duct is injured, pneumothorax if the pleura is injured, catheter or wire shearing. Complication due to catheter presence is thrombosis, thromboembolism, infection, sepsis, and endocarditis. Arrhythmias, most common is complete heart block and ventricular fibrillation. It can be limited with the guide wire length up to 22 centimeter. Hydrothorax, if the catheter is not in position in the vein, RA or RV perforation and tamponade. And that's also.
You finished?
Yes, sir.
I think the description of anatomy is very inadequate. You just mentioned
Okay.
it is a vein coming from a continuation of the sigmoid sinus and drains into the right atrium through the brachiocephalic formation. But what are the
Yes,
other
sir.
relations right from the base of the skull down to the clavicle? What is the posterior relation?
Oh.
What is the, see, anatomy questions always we talk about the relationship in the posterior side, anterior side, medial side, lateral side, and its relationship with
Okay,
the
okay.
artery is just not the common carotid lower down, only to the triangle formed by the two heads of the sternocleidomastoid. Initially, when it
Okay.
comes out, what is the relationship? What is which artery is in relationship with the IJV? When it comes through the jugular foramen, your answer did not mention anything about the jugular foramen at all. What about the
I just
superior
mentioned.
jugular bulb and inferior jugular bulb? All these things have to be explained. Yeah. So,
Okay, okay, sir.
shall we go for present sharing?
Okay, okay,
Kamashi,
sir. Okay, sir.
you are hosting today, Ammu, or
Uh,
Dr. Kamashi is there?
Kamashi sir is there, sir.
Okay, I'll just try to.
Sir, I'm there, sir. Actually, I am connecting with two phones. Yeah.
Okay.
Shall we go on to the next topic, sir?
No. This
Sir,
topic is not
sir
at
want
finish.
to do a presentation, sir.
It is a.
Okay. I thought you were having
I
some
think
trouble.
it requires a little more detailed explanation about the anatomy that has not been completely covered in the presentation done by Dr. Ammu. And surprisingly, I thought she will make a wonderful presentation. Today she disappointed me.
Sorry, sir. I didn't know. Sorry, sir. I didn't know that you have to write like that, sir. Sorry,
Okay,
sir.
anyway, I'll just show you how to write it. So this is the internal
Okay, sir.
jugular vein. It is the paired vessel, that is, it is present on both sides, found in the carotid sheath on either side of the neck, and it extends from uh, the neck down to the that is from base of skull to the clavicle. That is the entire course of it. And the internal jugular vein receives 8 tributaries along its course. So it is not enough if you just say that it is draining the blood from the brain and the facial structures. Its function is to drain venous blood from the majority of the skull, brain, superficial structures, and head and neck. That is one thing. And so this is the whole course of the internal jugular vein, starting from the base of the skull when it comes out through the jugular foramen. From there you have to start. And then it has got a relationship to so many structures in the head, neck. And finally it comes and joins the subclavian vein to form the brachiocephalic. But the relationship with the artery, the main artery coursing along with the internal jugular vein, when it comes out of the jugular foramen, it is accompanied by the internal carotid artery, because the common carotid has already branched out into internal and external carotids. So at the level of the jugular foramen, it is the internal carotid artery which is accompanying a little bit down, at least about 1/3 of the distance when it comes, it becomes the carotid artery. There only it becomes the common carotid. And the common carotid initially is posterior, and lateral, what happens, the vein becomes lateral and carotid becomes medial. That is a very important relationship, because whenever you want to do the puncture, it is better to go as slow as possible so that you don't puncture the artery. If you do a higher up approach, because the artery is more superficial there, you will invariably puncture only the artery. So it is better that you go to a lower level, so that the artery is more lateral, and you can retract the artery medially towards the trachea and do the puncture without causing any damage to the artery. So that relationship will come, and you have to explain that. And this triangle you mentioned, this is unless they ask you specifically about the techniques of cannulation of IJV, you don't have to waste your time writing about what are all the various approaches that you will do, namely the superior approach, middle approach, anterior, posterior, all those things should be explained only when The question includes describe the anatomy of internal jugular vein, the techniques of cannulation, indications, complications. If that is the question, then you can spend more time on writing about the various approaches. But if that part is not asked, the techniques of various techniques of cannulating, because that sometimes they ask that itself as a full question. Describe the various techniques of cannulating the internal jugular vein. Then you have to give every detail about what is the position of the patient, how the neck should be, how the head should be, or what are all the landmarks you will palpate, where exactly you can puncture. You can draw various diagrams about the various positions of needle insertion. And then you can mention about the various approaches. But when the question does not have that segment of techniques is not asked, don't have to waste time on that. And this is a triangle through which commonly we make all the approaches. Superior, you puncture here and then aim it towards the ipsilateral lateral, middle, just go lateral, and then you come from posterior, all that. And this triangle, what he mentioned, even though it is written as STDILLOT, can anyone tell me what is the correct pronunciation of this name? Even though it is actually written as Sedilot. It is not that is not the pronunciation. It is a French name. So it is Sedio. Actually, it is a RUE. His full name is Rose Sedio. That is the way it should be pronounced because it's a French name. Even though you write the spelling as Sedilots, it is pronounced as Sedio's triangle. Here, this LL is silent there. So you just make a Sedio's triangle and then you go for that. But you don't have to go write all those various approaches. And see, originates within the posterior part of the jugular foramen under the posterior part of the floor of the tympanic cavity. IJV continues with the sigmoid sinus inside the skull. However, the origin is demarcated by a dilatation called the superior bulb of internal jugular vein. So this is the picture. You can see this is the sigmoid sinus. When it comes out, this green part is the internal jugular vein, and this is the arrow mark shows the bulb, superior bulb. What is the important applied anatomy of this superior bulb? What is the importance of knowing about the superior bulb of the internal jugular vein? Dr. Ramu. Or anyone else can answer that? Okay, I will give you a little more time to think about it. You can Google also and find out before I finish that.
Okay,
Otherwise, I will tell you the answer at the end of this presentation of this. So, internal jugular vein passes the jugular foramen through the with the internal carotid artery. So, at the origin level or the starting point at the base of the skull, it is only in relationship to internal carotid, and it lies posterior to the artery there. This is that is vein is more anterior. I mean the artery is anterior and vein is more posterior. And with the glossopharyngeal, 4 cranial nerves are accompanying there. Cranial nerve 9, 10, 11, and 12 passing between the adjoining surfaces. That is, for these 4 cranial nerves are traversing between these 2 vessels. And the internal jugular vein then traverses the carotid sheath, descending in a nearly vertical fashion down the neck. And within the sheath, the IJV lies lateral to the common carotid artery and vagus nerve. This is a very, very important relationship that has to be mentioned. And the IJV ends posteriorly to the sternal end of the clavicle by merging with the ipsilateral subclavian vein and forming the brachiocephalic or the innominate vein. And prior to its termination, IJV usually features a terminal dilatation called the inferior bulb of internal jugular vein. So there are 2 dilatations. One is the superior bulb and second is the internal jugular vein. So when will you cannulate the IJV in the reverse fashion? I am just giving a clue for the question I asked. What is the importance of the superior bulb? Normally, when we puncture and cannulate the IJV, we always pass it towards the heart, towards the superior vena cava, isn't it? Whether to measure the CVP or whether to give fluids, we all do that only for mainly fluid resuscitation or drug administration on the various indications what you mentioned. But when will you pass a catheter in the reverse direction towards the bulb at the base of the skull? When you want to
Thrombectomy,
measure the
ICP monitoring பண்ணேன்.
not
Uh,
venous
exactly. When you
it-
want to measure the jugular venous bulb oxygen saturation, that is which is an indication of your brain also blood supply. Okay, so the brain blood supply is indirectly measured by the jugular venous oxygen saturation. So for that, instead of passing the catheter through towards the heart, we send it in the reverse direction and place it at the superior bulb or the dilatation that is present at the internal jugular vein. So that is where it becomes important. And then coming to the relationship from the skull to the clavicle, I just grossly mentioned what are all the relationship. And posterior aspect, you have rectus capitalis lateralis, transverse process of atlas, and scalenus anterior, cervical plexus, phrenic nerve, thyrocervical trunk, vertebral vein, and subclavian vein. All these things from above downwards, if you trace, these are all the structures to which it is related. When you see the anterior aspect of the vein, except for a short superior portion, lies deep to the sternocleidomastoid muscle. And below the sternocleidomastoid muscle, anterior surface of the vein is crossed by the posterior belly of digastric and superior belly of omohyoid muscles, which divide the vein into three areas. That is, the course it is traversed is divided into three areas. The area of the vein above the posterior belly of digastric muscle is crossed by the parotid gland and styloid process and accessory nerve, that is the 11th cranial nerve, and posterior auricular and occipital arteries. So many structures are there in the first part of that division, the rough division made by the digastric muscle. Now, the area between the bellies of digastric omohyoid muscles is crossed by ansa cervicalis and the muscular branches of the superior thyroid artery that supply the sternocleidoid muscles. The area below the omohyoid is related to the sternocleidomastoid directly, as well as infrahyoid muscles and posterior anterior jugular vein. So this is the picture to show that. See, this is the posterior belly of digastric. This is the superior belly of omohyoid, and so this triangle divides it into one part, two parts, and three parts. So the digastric and the omohyoid. So the spinal accessory nerve, inferior root of cervicalis, and anterior jugular vein, the various muscles, they are all posterior auricular artery and occipital artery. So two arteries, two muscles, two nerves are in relationship. And one vein is also, that is anterior jugular vein is also in relationship with that. So these are all called the internal superficial relationships of IJV. And the deep relation, this is the picture shown in the earlier slide. Rectus capitalis, transverse process of atlas, levator scapulae, scalenus medius, scalenus anterior, phrenic nerve, vertebral vein, thyrocervical trunk, first part of subclavian, and internal jugular vein outline. All these things are shown in this picture. So even if you are not able to fully write or draw these pictures, you must be able to recall and write all these relationships. So this much should be written for the anatomy.
Okay,
And of
okay.
course, this is the picture I am just showing to give you an idea about the ultrasonography. This is not in relation to the answer, so you can just remember it as a method of cannulating the IJV. I just thought I will include that. And coming to the internal indications, of course, all the indications and complications you mentioned very well. Anyway, just to recap that, for long-term venous access, when it is not possible from other sites, and the inability to obtain peripheral venous access or intravenous infusion, IV infusion of concentrated or irritating fluids, IV infusion of high flows or large fluid volumes when it is required, which cannot be done by mere peripheral venous catheters, and monitoring of central venous pressure, hemodialysis or plasmapheresis, transvenous cardiac pacing, placement of IVC filter, that is also sometimes done through this, and pulmonary arterial monitoring through the internal jugular cannulation. Contraindications, of course, they can divide them into absolute and relative contraindications. The absolute are IJV thrombosis, local infection, and antibiotic impregnated catheter in allergic patient. And the relative contraindications, coagulopathy, including therapeutic anticoagulation, local anatomic distortion, trauma, or congenital malformation or gross obesity, SVC syndrome, severe cardiorespiratory insufficiency, or increased intracranial intraocular pressure, patient will be compromised because of the slight Trendelenburg position we have to give, and history of prior catheterization of the integrated central vein, uncooperative patient, left bundle branch block, as guide wire can produce a complete heart block, and the complications are arterial puncture is very, very common, most common complication because of the wrong approach, hematoma because of that puncture of the artery, and pneumothorax in the low approach when you go close to the pleura, damage to the vein, you can go through and produce a damage to the IGV itself, that can lead to hemothorax, air embolism, catheter misplacement, arrhythmias, atrial perforation, and nerve damage because so many nerves are in close proximity with the IAV, and infection. And I have put one red capital letters, CLABZ. What does that CLABZ mean?
Line associated bloodstream infection.
Central line associated bloodstream infection. So it is not mere local infection, it can produce a entire bloodstream infection. So you have to be very meticulous with your asepsis, and thrombosis, and rare complication of catheter displacement, and hydrothorax, hydromediastinum, damage to the tricuspid valve. All these things can happen, and guide wire catheter embolism also can occur. Okay, so these are all the things that you have to mention about IJV. So just remember that you have to go for a more description of the anatomy. Okay, so you can include that part of the anatomy answer that I give in your preparation so that you can get the correct marks.
Okay, sir. Okay. Thank you, sir.
Thank you, sir.